Welcome to today's Newsmaker interview. Today, Marvin Olasky, editor of World Magazine and distinguished professor of journalism and public policy at Patrick Henry College, will be interviewing for publication in the World our special guest, John C. Goodman. Dr. Goodman is president and CEO of the National Center for Policy Analysis and a research fellow at the Independent Institute. He's regarded as a leading national authority on conservative approaches to health care. He's been called the father of health savings accounts. So all of us employees at Patrick Henry College, he saved us a lot of money, so we have to thank him for that. Frequent witness before Congress on healthcare reform. His health policy blog is one of the premier healthcare blogs on the internet, tapping the expertise of top national health policy experts to provide private sector solutions to healthcare problems. He's the author of more than 50 studies on health policy and of 9 books, including Leaving Women Behind, Modern Families, Outdated Laws. His forthcoming book, Priceless: Curing the Healthcare Crisis, unveils the maddening complexity of the healthcare system and demonstrates that it cannot be managed from the top down. As many of us suspected, and contrary to the core premises of Obamacare, Dr. Goodman's research suggests that true reform must liberate doctors and patients to interact in innovative ways to meet unique individual medical needs. Conversely, he states, the present system is fraught with perverse incentives that raise the cost of health care, reduce its quality, and make care less accessible than it should be. Dr. Goodman was the pivotal lead expert in the grassroots public policy campaign Free Our Health Care Now, a national education effort on patient-centered alternatives to a government-run healthcare system that triggered the largest online petition ever delivered on Capitol Hill. He received his PhD in economics from Columbia, and he's taught and completed research at Columbia University, Stanford, Dartmouth College, Southern Methodist University, and the University of Dallas. Please join me in welcoming to Patrick Henry College, Dr. John C. Goodman.
Here's John's new book, Priceless: Curing the Healthcare Crisis, a book that I suspect will make a large impact. But let's start out by talking about a previous book that had an impact, Patient Power. What did that book succeed in accomplishing, and what did it not succeed in accomplishing?
Well, 20 years ago, I co-authored the book Patient Power, and the most important thing it did was it introduced into the public policy arena the idea of a health savings account. And at that time, nobody knew what a health savings account is or was. Today, 27 million Americans have these accounts, and they're managing some of their own healthcare dollars and making their own decisions about how those dollars are spent. And when patients manage their own money, they make better decisions than when they're spending someone else's money. And when patients are managing their own money over on the supply side, then doctors start competing on the basis of price and quality as well. So it caused a revolution in thinking about healthcare, but it didn't go far enough, and that's why we've got to have a second book 20 years later.
Okay. So when many of you were small children, there was a big healthcare debate that went on in this country in 1993 and 1994, what was then called Hillary Care, after Hillary Clinton. And that attempt to create a big national system was unsuccessful. Republicans in 1995 had a majority in the House of Representatives, and there was a period early in this century when Republicans actually had the White House and had a small majority, briefly, in the Senate. And during that time, what happened in healthcare reform?
Oh, Republicans not only didn't do the right thing, they eventually wound up doing the wrong thing, which was expanding Medicare to prescription drugs and covering 80% of seniors who already had coverage for prescription drugs, essentially giving away taxpayer dollars that we didn't have to give away to create one more unfunded liability. So Obamacare, of course, does the same thing. But Republicans weren't very good when they had the reins of power.
Okay, so opportunities missed there, and thus we have the events of the past several years.
Yes. The one good thing that the Republicans did was they gave us the health savings accounts, and I really think those are going to become increasingly important. But I've got to tell you, in the Obamacare legislation, there are some real threatening things. And if we don't change something, Obamacare will wipe the health savings account out of the individual market for health insurance. And it will restrict, in important ways, their ability to be used in the employer market.
So you mentioned the prescription drug benefit, the expansion of Medicare. That was presented with the idea that, and as are the other healthcare proposals, I mean, let's not assume ill will on the part of liberals. Let's say that they really want to help the people who have been underinsured or uninsured or elderly or so forth. What you're saying with the prescription drug benefit is that despite perhaps good intentions, it didn't actually help a whole lot?
Well, the prescription drug benefit, well, let's back up for a moment.
Yeah.
Medicare is really a bad insurance plan. It has all kinds of holes in it. And one of the big holes was it didn't cover prescription drugs. So it didn't have the kind of coverage the rest of America had. And so instead of opting for health plans that look like the plans that non-seniors have, Congress just tacked on one more benefit, and that was prescription drugs. And it's 75% subsidized by taxpayers. And but 80% of the seniors already had coverage of their own, which they purchased in the private marketplace, or they got through an employer, or they got through Medicaid. And so we ended up spending an enormous amount of money that we didn't need to spend to pay for coverage that seniors already have. And the unfunded liability going out forever was greater in this new drug program than the unfunded liability in Social Security. So the irony of all this is we had President Bush, who ran for president twice, saying we've got to do something about the long-run finances of Social Security. Not only did he fail to do that, but we created a new program with an unfunded liability greater than the problem that he promised to solve. So not only did we not solve the problem, we doubled its size.
And for 80% of the people, then, it really did not do anything to improve their health. It just transferred the payment plans from private to governmental, and thus adding to the deficit.
Right. They got to keep more of their own money, and the rest of us are paying for more of their own drugs, more of their drugs.
Okay, now let's talk about another area, children who are uninsured. And so there are CHIPS programs. Yeah. How did that help, or did it help those kids?
Well, CHIPS programs is, of course, for low-income children, and it's like the Medicaid program, which we've had for many years, and it's highly subsidized, and the idea is to provide free health insurance to children. The problem is that when you offer something for free, people are paying premiums for private coverage. Their incentive is to drop the private coverage in order to get the free coverage. And the estimates are that, that 1 out of every 2 children, or maybe even more, that enters the free government program drop their private health insurance in order to get there. Why is that bad? Well, it's bad for the taxpayer, for one. But also with private insurance, they could see any doctor that they wanted to see. But under the CHIP program, because the payment rates of doctors are so low, they have trouble finding doctors who will see them.
Okay. Medicaid. Mm-hmm. Again, a plan put forth by lots of folks with, I think, good intentions of helping the poor. How has that worked out?
Medicaid is a lousy insurance plan. It pays very low rates. The biggest problem with people on Medicaid is they can't find a doctor who will see them. I was in Boston not long ago, where we're told they have universal coverage these days. And I asked a female cab driver how the system was working for her. And she said, well, she was on Mass Health. Mass Health is Medicaid in Massachusetts. And she said, well, I guess it's okay, but I'm having trouble finding a doctor who will see me. And I said, oh, well, tell me about that. And she said, well, I went down a list of 20 names before I could find one who would take me. And I said, were you going down the yellow pages? She said, no, I was going down a list that Mass Health gave me. And this gives you some idea of what kind of coverage you get when you get covered by Medicaid. And there's also lots of evidence that the quality of care that people get is not as good in Medicaid. And here again, we also have crowd out. Every time they expand the eligibility for Medicaid, people drop their private insurance to get it, and the crowd out is about, about half of the people who move into Medicaid previously had private insurance.
So I'm asking these questions because it seems to me this is a vital point to get at. From the history of welfare reform, and back in the 1990s, as long as there was a battle of the way it was portrayed as economics versus people, then there were some people who said, you know, whatever it costs, we got to do this stuff to help folks who are in desperate need. And there are other folks who said, gee, we can't afford this and so forth. But, you know, this is a very affluent country, and at least in the 1990s, we could afford lots of stuff. But the debate changed when people started to realize that these plans, these governmental programs, aren't actually helping the people that they are intended to help. So I'm wondering if in terms of the current healthcare debate, you know, we're in somewhat of a different situation now because we can see the devastation of just the rapidly increasing debt that a lot of the students here will have to deal with. But I still wonder if it's put primarily as a question of finances versus helping people. That's going to lead some people to be for it, some people to be against, and so forth. We have to look at the question of what the results are, right? Not just the intentions.
Yes, I don't like the putting money against people's needs because I don't think that's the best way to frame the issue. There's a certain amount, we're spending an enormous amount of money, and the problem is we're spending it the wrong ways. And what happened in the CHIP program is a recent study found that when children enter the CHIP program, they don't get more care. They don't get any more doctor visits than they had before. The only thing that gets them more doctor visits is paying doctors a higher fee. But we make it illegal for the parents to add to the CHIP payment to pay doctors a higher fee. So we push them in a program that gives them insurance, but they're not getting more medical care, and then we say we're going to make it illegal for you to add some money of your own and pay the doctor enough to want to see you. So it's enormously wasteful. You have bad programs crowding out good, which is Olasky's law, by the way, and it's bad for the taxpayer and not good for the people trying to help.
Okay, since you've been kind enough to mention Olasky's law, I need to mention Goodman's theorem here. And here it is. Because I asked John about this earlier, and he didn't quite remember what Goodman's theorem is, but it's in the book. Although some habits of highly successful people can be identified and copied, not enough of them can be copied for each of us to become highly successful ourselves through copycat behavior. It's a great theorem. Now, could you explain it to us?
Sure. Barack Obama's theory of how to reform health care is you go out and you run pilot programs and demonstration projects, and if you find something that seems to be working, then you go copy it. It's the same approach he's taken to education, by the way. The only difference is in education, we've been trying to do this for 25 years with no success, and now we're finding out we're having no success in healthcare. And so I asked in my book, well, why is it this doesn't work? And I imagined that we could follow around Warren Buffett, who's the famous billionaire, all day long and write down everything he did. Could we then copy everything he did, and could all of us become billionaires in that way? And the theorem says no, that doesn't work. And just as we can't become billionaires by copying Warren Buffett, we're not going to find the healthcare system that works by trying to copy something out of a demonstration project.
Okay, you mentioned Frederick Hayek's concept, and that's an economist a lot of students here either are or will be familiar with. He talks about the fatal conceit. Could you explain that and show how that helps us understand the healthcare debate?
Well, the fatal conceit is the belief that people can manipulate and control complex systems that they don't understand and have good outcomes. And invariably when they try to do that, the outcomes are not only good, but they get all kinds of unintended consequences. And I compared it to walking into a chemistry lab and pouring things from one beaker to the next, even though you don't understand anything about chemistry. Or walking into a nuclear power plant, start pushing buttons even though you don't know anything about nuclear power plants. Well, that's what policymakers are doing in healthcare. They're changing this rule and changing that rule, and they have no idea what the consequences of their actions are going to be.
So it's a very complicated system. Is anyone smart enough to really grasp what's going on?
No. Complex systems, by definition, are systems that no one of us can fully understand. And the healthcare system is the most complex of all social systems. And so each of us just sees a small part of it. We see our interactions with the doctor, with hospitals. But there are in this country more than 300 million people and 800,000 doctors and thousands more nurses and hospital administrators. And all these people are interacting in complex ways, and we don't understand it at all. And as a consequence, when we try to manipulate it, we're often surprised by the results. One surprise that I think is going to shock a lot of Democrats in Congress who voted for Obamacare, thinking they were going to help low-income people, I think they're going to be surprised when they find out that access to care is actually going to go down for our most vulnerable populations instead of going up.
Why?
Because what's about to happen, it's already happening, but it's going to happen in a big way in a year and a half, is that we're going to insure an additional 30 million people. And if the economic studies are correct, those people will try to double their consumption of health care. Then all of you, all the rest of the country, is going to be pushed into more generous insurance than we otherwise would have chosen. And there will be a whole long list of preventive care that we get to have with no deductible, no copayment. And so when we have these benefits, we will be inclined to go take advantage of them. But so what I'm describing is a huge increase in the demand for medical care. But there is in the Obamacare no increase in supply. There's no provision to create any more doctors. This is exactly what happened in Massachusetts under Governor Romney. They increased demand but didn't change supply. So the waits to see a doctor in Massachusetts are longer than anywhere else in the country. The wait to see a new doctor in Boston is now 2 months. The rest of the country is 3 weeks. So what's going to happen is we're going to have a rationing problem. Not everyone can see the doctor when they want to see them. The doctors, being rational human beings, are going to tend to see those patients first who pay the most. And so if you're in a plan that pays below market, you'll be pushed to the end of the waiting line. Well, who are those patients? They're the elderly and the disabled on Medicare, poor people on Medicaid, and if the Massachusetts example is followed, the newly insured people in the health insurance exchanges, those plans will pay just a little bit better than Medicaid. So I think access to care for our most vulnerable populations will actually go down under Obamacare.
So is the next step basically ordering doctors to not make their own decisions about patients, but to take a certain list given to them?
It's very, very hard to order doctors to take patients in any particular order. That's a degree of government intrusion that you don't see even in the socialist countries. Okay. So it's just very hard to do that, and I can't imagine that politicians will try. Remember, for most low-income people, they already experience rationing by waiting. So in Dallas, Texas, for example, it's very hard for a patient on Medicaid to find a doctor who will see her. And so she goes to the community health centers, or she goes to the waiting room of the emergency room of a safety net hospital. Parkland Hospital in Dallas, the average wait would be 4, 5, 6 hours, depending on the day of the week, just for basic primary care. Now, if you're bleeding all over the floor, they're going to see you quickly. But if you go in with a migraine headache, you could wait all day before someone sees you.
So I just want to nail this a little bit, that when people talk about a lack of access to care now, and you're saying that in the new healthcare regime, poor people would be able to double, theoretically, their access to care. If they could do that, would that make them twice as healthy, essentially? Is there, what relationship have we seen between more frequent visits to the doctor and patient health?
Well, just to clarify one thing, we're going to double the number of people who with insurance, but not all of those people are poor.
Okay.
In fact, a great many of them are middle class. They just are not paying premiums.
Okay.
Now, there's not much correlation between the number of times we see doctors and our health. In fact, there's not much correlation between the amount of money or the doctors we have and our state of health nationwide. If you have two cities and one city had twice as many doctors per capita as the other, or twice as many hospital beds as the other, you wouldn't necessarily find any difference in life expectancy. And that's a surprising result, but that's been shown again and again and again in studies of how healthcare affects us. So healthcare affects us at the margin, but it doesn't, given where we are, more visits, more spending isn't going to add much to life expectancy.
So is that because a lot of health, a lot of life expectancy is more genetic than something that we can change through our healthcare?
Mainly the reason why we die is because of lifestyle, environment, and genes. And mainly if you really get sick, the healthcare system really does take care of you. And just spending more on healthcare countrywide is not going to improve the nation's life expectancy very much at all. And that's not only true in this country, it's true throughout the developed world. There's almost no correlation between what countries spend and the general mortality of the population.
But there is a correlation between certainly behavior and the general health in terms of smoking, in terms of obesity, in terms of sedentary rather than an active lifestyle. So what incentives are there for people to try to change behavior when some of that behavior is contributing to ill health?
Well, in this country and in other developed countries, there's no incentive at all, because our basic policy is that you're going to be on a public program. Certainly by the time you get to be 65 years of age, you qualify for Medicare, and that's heavily subsidized by the taxpayer. And that's when your lifestyle begins to pay dividends. And if you made all the wrong choices, that's when you start getting sick and needing care. And but you don't pay the cost of that care. So we subsidize bad behavior through our healthcare system. Yeah. But so does every other developed country.
We've at World Magazine, we've had reporters this summer going around the country and talking with a lot of doctors at charity and free clinics, and they talk a lot about the importance of behavior and really working with patients to change behavior. If in fact there's no incentive at all to change behavior, and the idea is that you actually can't do anything yourself. You're going to go to a medical office, and someone there is going to take care of you, whatever your situation is. Then does that make things worse? The psychology then that you're really a helpless person until you go to the medical and they're going to fix you up or something?
Well, we have very poor incentives on both sides of the market. Patients don't gain very much by changing their behavior, and we're not doing anything to incentivize doctors and hospitals and clinics to change behavior. Can I use the example of Jeffrey Brenner?
Okay.
This is a doctor in Camden, New Jersey, which is one of the poorest places in the whole country. And Brenner is a real entrepreneur. He goes through the hospital records, and he discovers that 1% of all the people in Camden are responsible for 30% of the hospital cost. So he goes down the list of patients. He finds one of the worst cases. This is a man who weighs more than 600 pounds. He's an alcoholic. He's a drug addict. He's a diabetic. He spends half the year in the hospital. The other half of the year, he's outside the hospital abusing himself. So Brenner takes this guy under his wing. He enrolls him in AA, Alcoholics Anonymous, gets him off drugs, gets him off alcohol, discovers the guy's a Christian, gets him going to church, gets him to sign up for some welfare programs so he can have some financial stability in his life. And all of a sudden, this man is losing weight, getting healthier, and not going in the hospital. And so the costs go way, way down. And given that one very good example of success, Brenner then found other patients whose costs could be brought down just by changing behavior. Of course, what Brenner is doing here is social work. Now, he's saving millions of dollars for Medicare and Medicaid, and yet how much do you think Medicare pays him for all the millions of dollars he saves Medicare? Zero. The same for Medicaid. And that's because they have a long list of things they pay for, and social work really isn't on the list. And so Brenner's doing all this good for society, but we're not doing anything for Brenner. What I said at my blog is we should let Brenner become a millionaire. Let's say to Brenner, every time you save the taxpayer dollar, we're going to give you back 20 cents. And let's hope he does become a millionaire. And then let's tell all the other doctors in the country, if you can figure out how to lower our costs and improve quality, you tell us to pay. You want to be paid a different way, we'll pay you a different way. As long as you're saving the taxpayer money and helping the patient, we want to pay you in a different way. That's the opposite of the way they think in Washington right now.
Okay, so you've just talked about a really hard case. Let's talk about someone who doesn't have those behavioral problems, doing everything right, and then something disastrous happens in his health. how would you create incentives to try to help a person in that situation?
Well, of course, that's why we buy insurance.
Okay.
Because we can all have the unexpected accident. We can have unexpected damage to our car, to our home, and to our body. And that's why, and when those unexpected expenses are large, that's why we want insurance. But for the smaller stuff, I've thought that people ought to control their own dollars and make their own decisions, and that's the whole motive behind the health savings account.
Okay. So at this point, I mean, we see the problems here. At this point, with the Affordable Care Act, Obamacare passed, and so forth, what do you do right now?
Well, I suggested to the Congress last month that they adopt a health contract with America. Now, all of you are too young to remember, but 15 years ago, the Republicans had a contract with America, and that's how they took over the Congress. They said, if you give us control of the Congress, we're going to do these 10 things. I said, well, let's do this with health care. Endorse 5 principles that are easy to understand. And they actually put them up at the Congressional Health Care Caucus. And so there are some people who like them. But one idea was tax fairness. Let's treat everybody the same with regard to health care. Right now we don't. It's very arbitrary and very unfair. Obamacare makes it more unfair. So just give every American the same number of dollars or refundable tax credit for health insurance. Same dollars no matter where you get your insurance. And then let's encourage portable insurance. Right now, it's illegal for employers to buy for their employees insurance which they own and can take with them from job to job. That's crazy. At my organization, the National Center for Policy Analysis, we can only buy group insurance, Blue Cross Group, which the employee loses when he leaves. We're not allowed to buy Blue Cross Individual, which the employee would own and take with him. So we need to turn that completely around. And so there are about 5 ideas just like this that I think that people could understand, and it would be a reasonable alternative to Obamacare.
Okay, so you're talking about incentives, you're talking about prices. In this book you say there's a religious quality to the way some people think and talk about health care, and basically saying that a lot of folks find the price system in regard to health care, incentives in regard to health care, they find that distasteful. So why is that, and then what do you do about that?
Well, I find that when people start talking about health care, I hate to put it this way, but it's almost like their IQs fall about 15 points. I don't know what it is, but just a lot of people have trouble not just thinking in economic terms, but even thinking rationally about health care. And one of the biggest mistakes they all make is to think that health insurance is the same as getting health care. So how many times have we heard it said that in Massachusetts, Governor Romney's reform cut the number of uninsured in half, which is true, it did. But there's no evidence they're getting any more health care. They didn't create any more doctors. No, they didn't create new nurses or health clinics. Same number as were there before. As far as anyone can tell, people are going to the same places they went before to get the same health care they got. Governor Romney told me back when this was first being initiated, once we get this plan in place, people won't have to go to the emergency room. That's an expensive place to go get care. They will go to the primary care physician at his office. Well, just as many people are going to the hospital emergency room in Massachusetts today for health care as before the reform. So apparently very little has changed. We're just moving money around. And the mistake these policymakers make is they think that health insurance equals health care. It doesn't.
So health insurance doesn't equal health care. We hear sometimes about the Canadian system or the British system and how good that is, and you're saying that doesn't really equal better health care either.
No, in Canada, health care, by the way, we're not that different from Canada. In Canada, when you go to the doctor, you don't pay anything. In the United States, when you go to the doctor, on average, every time we spend $1, only 10 cents is coming out of our own pocket. So the other 90 cents is paid for by the employer, by the government, or by an insurance company. So we're not as different from Canada as a lot of people think. But in Canada, it's even more bureaucratic than our own system, and even though it's free, Canadians are not getting as much primary care as we get, and even uninsured people in the United States get more preventive tests than people in Canada. They get as many or more mammograms, pap smear tests, prostate cancer tests, more colonoscopies. So even our uninsured are getting more primary care than the insured in Canada.
So, still trying to get at this, and maybe it's right here in the title of your book, Priceless. People on one side tend to look upon health insurance, medical coverage as priceless. That is, we should pay any amount of money whatsoever for it. You're using the word priceless in a different way, that without prices, you really don't know what's going on. You don't, the prices are signals for what's working, what's not working, and we are really devoid of the information we need.
Right. By the way, the title of the book is a double entendre. On the one hand, your health care is priceless, but on the other hand, we've taken all the real prices out of the healthcare system. So nobody ever sees a real price. No patient, no doctor, no employee, no employer. The biggest mistake, the single biggest mistake we've made in healthcare is the same mistake all the other countries have made. And that's the belief that the way you make healthcare accessible is that you make it free at the time of delivery. You shouldn't have to pay money for care. And what we forget when we think that way is if money isn't going to be important, all the non-price barriers to care become that much more important. Now, what's a non-price barrier to care? It is, how long does it take you on the telephone to get an appointment with a doctor? How many days do you have to wait to see that doctor? How long does it take to get from where you are to the doctor's office? How long do you have to wait once you get to the doctor's office? Those are non-price barriers to care, and there's lots and lots of evidence that those things are bigger deterrents to health care than the fee the doctor charges. And so we pushed low-income people into these health plans where we erect all these non-price barriers, and then we say you are not allowed to take money out of your purse or out of your pocket and pay extra to pay the market price. You know, there are, just give one example, there are in the United States 1,300 walk-in clinics. They're in CVS pharmacies, they're in Walmart. The CVS pharmacies are called minute clinics. And the reason for that name is they're saying we know your time is important as well as your money. And you get low-cost, high-quality, efficient care. In Dallas, Texas, a minute clinic charges $75 for a throat problem or ear problem. Medicaid pays half that. We make it illegal for the Medicaid patient to take money and add to what the government pays and pay the market price. So they don't get access to the minute clinic. So we could make health care accessible overnight to millions of poor people just by allowing them to pay cash on top of what the government pays.
Okay. You can see what we're trying to get at here. If some of you have taken or you will be taking courses in writing, you'll probably hear about the ladder of abstraction. And the idea is that a good writer should function generally pretty low down in the ladder of abstraction with specific detail and human interest and the reality of things rather than just operating theoretically. And there seems to be a divide in some ways between those who operate theoretically and thinking about healthcare and what actually happens at street level. So time now for your questions. And I'd particularly encourage street level questions in a sense. What's the reality? What actually goes on? Not so much what people might aspire or like would happen, but what actually happens and what could happen with a system that was wiser concerning incentives and perhaps what's priceless and what's not. So questions from any of you?
Hi, can you comment on how the complex Medicare, Medicaid business affects small businesses?
Well, this is going to be terrible for small business because it's going to force those firms to provide a health insurance plan that is going to be dictated to them. And the average cost for family coverage is going to be about $15,000. So if you have a McDonald's franchise and they're paying people, let's say, $15 an hour, well, the health insurance is equal to half their wage. There is no new help in the bill for McDonald's. And as a consequence, I'm afraid the employees, a lot of employees are just going to lose their jobs. If they don't lose their jobs, they're going to lose a lot of pay. And they're going to be forced to take health insurance they may not want or even need. It's a very costly thing to do, and it's certainly not going to help us get out of recession. And a lot of people, including me, think this is why we have a jobless recovery. In other words, we're kind of, it's the worst recovery we've had in forever, and people aren't hiring. Businesses aren't hiring. They're not hiring because they don't know what it's going to cost them to hire a new employee.
In the Olympics opening ceremony, Great Britain had an odd little tribute to their national healthcare system, and I was wondering if if you saw that, or if you just plain have knowledge and can comment on what's going on in Great Britain, and if that's the average person's opinion or just some elite opinion of the people who made the ceremony.
Well, you know, they used to say in Britain that the British National Health Service is the envy of the world. And no one's saying it these days, even though they had the little tribute. The primary reason for the establishment of the British National Health Service was equality of access to health care. And all the British leaders said that. We want equal access to health care no matter what your social class, what your income, where you live, what your age is. That was the #1 objective. So this was back in 1948. So here we are 60 years later, and you might wonder, well, have they achieved equal access to care? And the answer is no. They got about 30 years into it, and they had a Royal Commission study to see how much progress they had made. And the Royal Commission said, we've made no progress at all. This is as unequal as it was 30 years ago. And then they went another decade, and they had another commission. They said, my gosh, things have gotten worse since the last commission report. So there's huge inequality in Britain. Plus, there's a private marketplace for care in Britain so that people can escape from the government and go get private care. So the British have totally failed in their objective of equal access to care. And in the meantime, they have rationing by waiting. They have thousands of people waiting months and months and months for care that you and I would get fairly quickly in the United States.
Dr. Goodman, first, thanks very much for coming. It's been very interesting listening to you. Also, like towards the end of your lecture or your discussion with Dr. Olasky, you seem to give quite a bit of examples where there was Medicaid plus like somebody adding additional cash to the system to make the payment reach market value, where that seemed to produce a good benefit. Can you imagine this kind of a system being good overall, or should just Medicaid? I know that you say that Medicaid is not a good thing, but is a system like that, can that lead to good things?
Most of you probably don't know how the food stamp program works, but basically we have 50 million people in this country on food stamps. And they can go into any supermarket you and I go into. They can buy almost any product we buy. They pay the same price that we pay. They get to the checkout counter, they put their food stamps down, they put cash on top of it, and they consummate the transaction. You never ever hear it said that low-income people don't have access to a supermarket. Now, there might not be one in their area. They may have to get on a bus to go to one, but there's no such thing as a supermarket that doesn't take Medicaid patients or food stamp people. But over in healthcare, the exact opposite is true. In healthcare, we have another 50 million people, and largely the same people, and we refuse to allow them to go into the minute clinic and add to the government payment and pay the market price. If we would allow them to buy primary care the way they buy food, we basically would eliminate most of the access to care problem for low-income families.
My dad is a physician, and he also runs his own practice. And so I was just curious about how Obamacare will affect him both as a physician and a small business owner.
Well, I would not relish going to medical school these days because what's going to happen is doctors are going to be pushed to practice cookbook medicine. Cookbook medicine means that the patient comes in with certain symptoms and you're supposed to treat them in a certain way. It's the opposite of individualized, personalized medicine. The way the science is going is toward a personalized medicine. You know, we can now take a small baby and test the genes and tell whether that baby is likely to get sudden death syndrome. And once we know that proclivity is there, we can do things to prevent the death. But it's all based on the genes of that baby, and there are only a few that have that genetic problem. That's personalized medicine. The Obama folks hate that idea. They want to treat us all as though we're the same. and they want doctors to all practice medicine the same way. And there's going to be enormous pressure to do it. And if the doctor follows the decision tree, the cookbook, he'll be paid more. If he deviates, he'll be paid less. So there'll be financial incentives to practice cookbook medicine. So the doctors are not going to be able to practice medicine the way they think they're going to be able to traditionally, and that's going to be one of the reasons for a lot of burnout and a lot of doctors retiring early.
What do you think of Paul Ryan's proposals that he's going to put forward for the coming campaign?
Well, I like Paul Ryan. I've helped him with some of the things he's doing. He's had to adjust now because Mitt Romney is the candidate. So they're not going to do exactly what Paul Ryan had in mind. But all the ads going back and forth, I guess you're probably seeing them here, aren't you? In Texas, we don't see them because we're not a battleground state. But all these ridiculous charges flying back and forth about Medicare, both candidates, both the Ryan budget and the Obama budget spend the same amount on Medicare going out indefinitely into the future. Ryan wants private plans to be available. Obama is not against that. We already have it going on. It's called Medicare Part C or Medicare Advantage. 1 out of every 4 seniors is right now in a private health insurance plan paid for by Medicare. So this isn't a new idea. It's not a radical idea. It's just two sides trying to pretend that there are huge differences when there aren't huge differences. Now, why the Ryan plan is better is that the only way Obama has to control costs and get the growth of Medicare down is to squeeze the doctors and squeeze the hospitals. The Medicare actuary has said if you do this, the way it's written in law, 1 out of 7 hospitals will go out of existence in the next 8 years, and the seniors won't be able to see a doctor. So Medicare will begin to look like Medicaid. Ryan, on the other hand, has not endorsed that approach, and so he's open to do some of the things that we at the NCPA think they should do, which is allowing the seniors to go into the Minute Clinic and pay the market price, allowing them to have health savings accounts to manage some of their own dollars. So Ryan is free to do better things to control spending, but in the aggregate, the two sides are planning to spend the same amount of money.
Let me just ask, right now there are more than 1,000 charity clinics in the country serving about 2 million patients. What will happen to those under Obamacare, and what would happen to those under Goodman care?
Mm-hmm. Well, let's go to Goodman care first. I want to empower people, and I want to give them accounts, and I want to give them control over their primary care dollars. So they could go to the charity center, or they could go to the Minute Clinic, or they could go to other places and actually pay something for their care. And so then you'd have competition in the marketplace. Under Obamacare, they don't really believe in patient power, and they don't really believe in markets, and they don't really believe in competition. And I'm afraid those charities will be squeezed out of the market. Again, remember Olasky's law, bad charity crowds out good charity.
Yeah, that's the way it's worked certainly in welfare and anti-poverty programs. Yes.
I guess I kind of had 2 questions. So speaking about like the ads flying around about both Obamacare and the Ryan plan, I just saw one yesterday where it was a study, like something about a study published by AARP saying that Obamacare is cutting down on fraud and the Ryan care is not doing that. So I was just curious specifically about AARP. I don't know a lot about them, but I mean, my dad gets mail from them sometimes. But I was just curious specifically about AARP. It's kind of easy to write it off as just a political thing, but I was just wondering if there's anything more to it than that, like a vested interest AARP has or something like that. And I guess the second question was, you mentioned that in all developed countries, kind of the same problem with healthcare that I think you called them the costless barriers, are like in terms of like how far people are from the doctor and stuff like that, those aren't addressed. So is there any country then that, or maybe in like another time period or something, where that has been done well? And if so, how did they do it?
Does everybody know what AARP is? It used to be called American Association of Retired People. Now it's just called AARP. They're supposed to represent old folks. The problem is that they sell Medigap insurance. And under Obamacare, because they're going to reduce the subsidies of these Medicare Advantage plans, half those people are going to lose their private insurance, and they're going to need Medigap supplements the holes in Medicare. So then who will they turn to? Well, we'll create a new market with 7 million new people, and ARP will have a chance to get a lot of those as customers. They make more money by selling Medigap insurance than they make by member dues. And so they supported Obamacare, in my opinion. They sold out their members. They sold out the seniors just for money. The same thing is true of the American Medical Association. They sold out the doctors because they make more money by selling or leasing their billing codes, which they have a monopoly on, than they get from member dues. And so we had, during this legislative process, some amazing things. Just all these people in Washington selling out their members in order to get more money in many cases. So that's my explanation for why they're behaving the way they're behaving, which is otherwise inexplicable. Now, are other countries doing anything that we like? In 1984, when I first wrote about health savings accounts in the Wall Street Journal, that very same year, Singapore started a system of MetaSave accounts. In Singapore, you're required to put 6% of your income every pay period into an account that you own and control. So they have mandatory health savings accounts. They work pretty well. South Africa, under Mandela, completely deregulated its insurance market. They had everything we have in the United States competing on a level playing field: HMOs, PPOs, health savings accounts. The health savings account plans basically dominate the market there, although the new government is pretty hostile toward them, and I'm fearful about where the future will go there. Switzerland is kind of interesting. You never hear liberals talk about Switzerland, but Switzerland has the most egalitarian system in the whole world. So you think, okay, if the thing you care about most is equality of access to care, what country's got the most equality? It's Switzerland. Switzerland, however, is mainly private insurance. It's mandated. You're required to have it, but it's individually owned. It's private. They have a competitive market. It's not nearly as free as I would like to see it, but it is certainly a lot more attractive than the other European countries. So there's 3 examples.
I'm curious if we're going to be seeing any increase in alternative care covered by insurance companies. I've gone to massage therapy school, and I'm wondering if that will continue to play more into health coverage, especially as we're looking at more personalized care. A lot of people find that alternative types are more appealing to them. And then two-part, I suppose. And then I'm also recently accepted back onto my parents' private insurance plan until I'm 26, and I'm 25 right now. And that was a happy day, I have to say, because I was able to go to the dentist for the first time in 3 years, even though that's really gross, and I shouldn't have said that. But I'm wondering, I almost feel guilty during a discussion like this. Am I a burden to the system? What is my role in that? Should I be buying private insurance for myself as of next year when I'm no longer covered, or am I mandated to do such?
Well, you'll be mandated to do such, but let's back up. There will be a mandated set of benefits, and for the first couple of years it will be determined at the state level, and then it will be federal. So the federal government is going to tell you what you have to have in your insurance plan. And I've already mentioned it has to cover all kinds of preventive services with no deductible, no copayment. That plan is already really expensive. I don't think you're going to find very many insurance companies offering more benefits on top of the mandates. It's just because the mandates themselves are going to be so expensive. Now, if you get insurance through an employer, you might have more options. But if you're off buying on your own in the individual market, I don't think you're going to find very many plans with more benefits. So the thing you have to hope for is they allow you to have a health savings account. Because the nice thing about the health savings account is you can go outside your plan and you have money to buy other services. And so that's the nice thing about empowering consumers in that way. Then their preferences are what get satisfied, not the preferences of a bunch of bureaucrats.
It seems to me
Well, just let me explain. What I mean by alternative, that's what I mean. You'll be able to take your health savings account money and buy alternative medical procedures that are not covered by your plan. Okay.
Zachary?
Apologize for that. Seems to me that the public discourse surrounding the healthcare debate has really degenerated so that it's hard to have meaningful conversations or to tell what the really good ideas are when the public discourse often consists of blame shifting and name calling. What have you found to be the most persuasive ways to speak to, number one, those in power in the government, and number two, the American people, ordinary individuals, in order to explain the positions that you hold in a convincing way that really gets down to the heart of the matter, the issues that are really at stake, rather than merely remaining on the surface of the partisan name-calling back and forth. What are some of the most persuasive ways to hold those conversations with those in Congress, perhaps, and with friends and neighbors?
Well, just to complete the picture that you've described, it's not only the politicians who are going for the sound bites and making ugly comments about each other that are not at all informative. It's worse than that. If you watch the Sunday morning TV talk shows or the evening TV talk shows, you find that the guests on those programs are just as bad as the candidates. And so they're just repeating the talking points of the candidates. And then if you pick up the New York Times and look at their lead editorial the other day on Medicare, it's nothing more than White House talking points. And so on the television and the newspapers, it's most of what you see is just talking points, not designed to inform anyone, but just designed to attack. And the one exception that I would cite is the Wall Street Journal editorial page, which I think has been very, very good on healthcare issues. But what I find is that the blogosphere is the best place to get real debates. I think the public policy debate is shifting to the blogosphere. I have a blog. It's called the John Goodman Health Policy Blog. If you want me to send health alerts to you, if you're really interested in this topic, give me an email address and you'll get something from me twice a week on this. But in any event, it'll take you back to the blog. But in the blogosphere, people are generally respectful. They don't engage in name calling. If they do, then people will just ignore you. And so the right and left really do engage each other. At my blog, I get lots of liberals, very recognizable liberals, but I also get conservatives, and they're debating with each other, and you get a real exchange of ideas, and mistakes get corrected, okay, because people usually in the blogosphere are willing to say, "Hey, I made a mistake," you know, and they don't just keep repeating nonsense.
Zachary, one thing I found persuasive and priceless along these lines is what happens when the great brain wants to take into account every single contingency in pricing of various medical cares. And John gives the example right now in Medicare in the new code book, ICD-10, 96 different codes for bites, including 3 different ones for being bit by a squirrel, initial encounter, subsequent encounter, sequel, 6 different codes for being bitten by a rat or mouse, different codes for injuries in art galleries, squash courts, 9 locations in and around mobile homes, et cetera, et cetera, et cetera. You know, that's what you have to do if you're trying to take into account the great brain, taking into account every single possible contingency.
Also, somebody asked earlier, what's it going to be like practicing medicine? You're going to have to deal with that kind of coding.
Yeah.
There's a lot of discussion about possibly returning Medicare back to the states and making it into a mostly state-run program. Do you think that would solve a lot of the problems that we have with Medicare?
Okay, it's Medicaid. Medicare, remember, is mainly for the elderly. Medicaid is for poor people, and Medicaid is 2/3 funded by the federal government and about 1/3 funded by the states. And yes, it should be block granted. And what a block grant means is the federal government just sends all the money it's going to send to the state and says it's your problem, deal with it the way you want to. You have to spend the money on indigent health care, but as long as you're doing that, we're going to let you make your own decisions. We're not going to tell you what services you have to cover. We're not going to tell you if you can charge a deductible or not. Those will be your decisions. And of course that's what we should do. And Rhode Island did that. And it's the only state that's been allowed to do this, and they save money for the whole system.
I may just, in countless guests that Marvin's interviewed in the past year, he's addressed health care and noted that the Republican Party has done no better than the Democratic Party in really addressing the core issues. In a Romney presidency, theoretically, do you see any hope? Have some of your ideas, analysis, and research in these areas of being addressed and turning the tide? And second part of the question is, if you were given authority and responsibility and resources over the healthcare industry in this country, do you think you could turn it around?
Absolutely. The Republicans are committed to repeal Obamacare. And there's no way they can get away from that. So they will either repeal it or they will severely gut it. But now if you ask, do they want to go beyond that and replace it with something better? Well, they've said they do, but when I talk to them, I don't find any real enthusiasm for the replace. Now, I went up to the Hill, as I mentioned. I gave them the health contract with America, 5 good ideas, and they put it up their website. But that's a far cry from passing legislation. I'm pretty close to Paul Ryan. I've worked with him for 20 years. Our idea of the refundable tax credit, which we trotted out 15 years ago, is part of a bill that he co-sponsored. It started over in the Senate with Senator Coburn, Senator Burr, and in the House it was Ryan Nunes. And so they took the idea right from us and they had a bill. But that's not part of the current campaign. They haven't reintroduced it. Romney hasn't talked about it. So I'm not hopeful that the Republicans are going to want to try to reform the system, even though it really needs reform. And what I would do, again, start with the taxes, start with the way we subsidize health insurance. Give people a fixed number of dollars. So I think we could give every adult $2,500, every family $8,000 for a family of 4. What that means is the first $8,000 of health insurance is really paid by your tax credit. Large employers are spending $16,000 on health insurance for families. So that would mean for that large employer, for those workers, again, first $8,000 is paid for with their tax credit. But the second $8,000 will all be after tax, whether it's paid for by the employer or the employee. So then they're going to have to start thinking, well, do we really need that extra $8,000? I mean, what benefits are we getting at the margin? Because every dollar we're now spending is a dollar we could take home and spend on something else. So I believe if you did that, very soon you'd find health insurance that only costs $8,000. May not give you all the options you now have, but people would have the ability to rethink what they really want and what they're really willing to pay for.
Actually, my question is very much in this one line. If we have time for one more here, David. But essentially, you have some great options for ways to reduce costs and some very good insight on some of the problems with the current healthcare system. Given the current fiscal state of this country, how much more damage financially would be done until things could be fixed, given a best case scenario for getting things fixed and given a very realistic scenario for getting things fixed?
Well, if we're talking about health care, I don't want to put any more money into the system. So when I talk about a tax credit, a generous tax credit, I'm talking about using money that's already in the system. Replacing all the tax and spending subsidies we now have with something better. If you're talking about the budget in general, we have to slow down health care costs because that's the reason for the federal budget deficit. The deficits that are growing for as far as the eye can see, they're all health care. If we didn't have a health care problem, we would not have a deficit problem. And how do you get control of that? By freeing the doctor, freeing the patient, freeing the employee, freeing the employer. This book is all about liberation. It's not about top-down controls. It's all about freeing people to solve the problems that only they will be able to solve.
Yeah, let's see. Kira, you have last question.
Well, thank you for coming today. I really appreciate it. And I'm probably going to reveal my ignorance right now on this complex issue. But a few moments ago, you said that you would give a certain amount of money to each individual for their health care, similar to food stamps. My question in regards to that is I have a set budget that I keep for how much I'm going to spend for food, which would be similar to what you'd give someone if you were giving them food stamps. But the very nature of health care is that you don't know when you're going to end up with a serious health problem. So by giving everyone the same amount of money, aren't you going to create a situation in which a lot of people have funding for things they don't need, and other people are not going to be able to get the care that they need?
That's a good question. Think of two kinds of insurance. Third-party insurance, which is an insurance company, and self-insurance, which is an account that you hold. People should self-insure for small expenses and for expenses over which there's a lot of discretion. Okay. So how often you go get mammograms, pap smears, other tests, there's a huge discretion, huge debate over whether you should get them at all. So let individuals have the money, make their own decisions about those sorts of things. Now, the really big things, you get hit by a car and your leg is broken, now you're in the hospital, that's expensive. So you need third-party insurance for that. And when I said that the government would give everybody a tax credit, to get the tax credit, they have to have catastrophic insurance. They don't have to give all the money to the insurance company. They can also have an account, that they own and control. But at a minimum, they have to have catastrophic insurance for the big items, or they don't get the tax credit. Okay.
Well, it's about time to wrap up here. I think what we've seen here, it's very complex, and in some ways this issue has to be debated on two levels. Number one, there's the level of street-level reality, what actually happens. And then number two, there is the level moving higher up the ladder of abstraction to talk about the role of freedom in all this, as John was referring. Chapter 10 of this book, he just uses that word over and over again. Freeing the doctor, freeing the patient, the employee, the employer, the non-traditional workplace, the uninsured, the kids, the parents, the chronically ill, the retirees. So, yeah, please join me in thanking John for looking at the reality and also emphasizing freedom.
So yes, thank you very much for being here. Really very stimulating and helpful. I hope all of you will come back tomorrow to hear the interview with Reverend Samuel Rodriguez, the leaders of the Hispanic Evangelical Movement. So we'll see you then. Again, let's thank one more time Dr. Goodman and Dr. Olasky.